Thank you, ma'am. Sorry, we'll go ahead with this today's topic. So my topic will be on the second paper, part 2 chapters. So you all know kidney, urinary bladder or lower urinary tract, and your MGT, FGT, breast, bones, joints, then skin, endocrine, soft tissue, and CNS will be included in this chapter. I'm going to do very important. I'm going to touch on only on the important topics, whichever will be repeatedly asked in your exams, and other things, few things which are very important for your MCQs part as well as for the practical part also. I'll be discussing on and off. Okay. Shall we go ahead with the first topic, that is kidney? So I think these are the important questions in the last 10 years from your previous question papers. I have got it down. So the most common will be your in Pondichery University, the most common will be usually post-streptococcal glomerular nephritis or a post-infectious will be the long question, and nephrotic syndrome. This all will be the, and renal cell carcinoma, Wilms tumor. So these 5 will be the usual long questions in this kidney chapter. And short questions, if you go 5-mark question, I'm saying rapidly progressive glomerular nephritis, minimal lesion glomerular, minimal change disease, and diabetic nephropathy, then chronic pyelonephritis, as well as sometimes this Wilms tumor has been asked in the 5-mark questions also. So these were the important thing which I have got, important questions which I have collected from both the Pondicherry University as well as from the Tamilnadu University. So these were the questions, you can take it down. So we'll go ahead with each topic. Just I'll touch up what you have to be written in your answer sheets, which has to be included in your answer sheets. Okay. So other short notes were kidney changes in malignant hypertension, flea-bitten kidney was repeatedly asked question, and renal stones, then hydronephrosis, then polycystic kidney disease, as well as sometimes in MCQs or in other short notes, very 2 more questions. This microalbuminuria and proteinuria has been repeatedly asked. 1 more question was in congenital anomaly was horseshoe-shaped kidney. Okay, so we go ahead with the normal things. So this all you will know, clinical pathological classification of glomerular disease. So it was been classified into primary glomerular nephritis, secondary systemic glomerular disease. So primary glomerular nephritis, you know, acute glomerular nephritis. This acute, under acute glomerular nephritis, we have 2 pattern of glomerular nephritis. One will be the post-streptococcal, the other will be the non-streptococcal. Then rapidly progressive, minimal change, membranous, membranoproliferative, focal diffuse proliferative glomerular nephritis, and focal segmental glomerular sclerosis. IgA nephropathy, I forgot to tell you, the last 2 years, this IgA nephropathy has been asked in the short notes. Okay. And 1 more question was amyloidosis was been asked. Then other important will be this vaginous granulomatosis and inoxidable in purpura. They were asking in the MCQs. Nowadays, MCQs has been included. So this has been asked in the MCQs. As well as the repeatedly asked question in nephritis will be the Alport syndrome. Okay. So glomerular syndrome, how do it clinically manifestates? You know, it starts from acute nephritic syndrome. It can be rapidly progressive, nephrotic, chronic renal failure, or sometimes asymptomatic hematuria or the proteinuria. So you can note it down. What are the clinical manifestations? So whenever they ask you the glomerular syndrome, this has to be included. Okay. So first will be the post-streptococcal glomerular nephritis. Usually we'll get a history of 12-year-old child presented with history of facial puffiness or hematuria or a sudden increase in the size of the abdomen or decrease in the urine output. The mother must be giving a history of past 1 week she had, and before some 10 days, the child was been suffering from the streptococcal infection or some throat infection with history of fever or something else. So it is usually followed by the post-streptococcal infection, which will be for 1 to 4 weeks, group A streptococcal infection. So it's an immune complex mediated against streptococcal antigen, endostreptocin and cationic antigen. So here what will happen? Usually the glomerulus will become hypercellular. You can see here there is an hypercellular glomeruli, infiltration of inflammatory cells. Here there you can see some neutrophils are there. You can see here, everywhere there is neutrophils are there. Then endothelial cells enlargement as well as mesangial cell enlargement will be there. And by immunofluorescence, you can able to see crescent deposition will be there in the subendothelium. Okay. So this rapidly progressive glomerulonephritis has been classified into type 1, type 2, and type 3. So microscopically rapidly progressive glomerulonephritis will have, you can able to see here subendothelial crescents are there. You can able to see here subendothelial and submesangial crescents will be there. And sorry, obliteration of the Bowman's capsule, and there can be thickened basement membrane which will be usually seen in the pars and the other special stains. Fibrin strands will be there in between the cellular stroma. So come to the other important thing, we'll go into nephritic and nephrotic syndrome. So whenever they ask you post streptococcal glomerulonephritis, you start with this, like you have to know what is the pathogens. You have to write about the immune complex deposition, where it will get deposited, and what kind of immune complex deposition will be there. Then gross usually will shows, kidney will shows mind enlargement. That's all. Then other lab investigation will shows either the nephritic picture, minimal proteinuria, and there can be a minimal lipiduria, and RBC's hematuria will be there in the urine. Then specifically, then microscopically, if you see, that's if biopsy was been done, hypercellular glomeruli with crescent deposition and inflammatory infiltration. This has to be completed in the post-streptococcal glomerulonephritis. So rapidly progressive, you should know what are the different types of rapidly progressive and what are the causes for this three types of rapidly progressive glomerulonephritis. And here also again it is a crescent deposition with the fibrin, intraglomerular capillary fibrin deposition, and inflammatory cells will be there in the urine space. Then comes to the nephrotic syndrome. You know the triad of the nephrotic syndrome: massive proteinuria, hyperalbuminemia, generalized edema, hyperlipidemia, lipiduria, and hypercoagulability states. So massive proteinuria will be usually more than 3.5 grams per 24 hours of loss of protein, more than 3.5 grams in 24 hours of urine sample. So causes of nephrotic syndrome in children, it is most commonly minimal change disease. Then comes to the focal segmental glomerulosclerosis. Whereas in adults, focal segmental glomerulosclerosis will be the most common. Then comes to your diabetes, that is diabetic nephropathy, or membranous glomerular nephropathy due to any causes. And then comes to your minimal change disease. These are the other systemic diseases. This can be asked in the MCQs. What are the other systemic diseases can present as a nephrotic syndrome? Most commonly diabetes, amyloidosis, systemic lupus erythematosus, and then other infections like hepatitis and HIV can present with a nephrotic syndrome. Malignancies, especially mucinous carcinoma, mucinous adenocarcinomas, and lymphomas can present with nephrotic syndrome. Okay, so this is a difference between your nephritic and nephrotic. You all know, start with your proteinuria, then triads of symptoms of nephritic and nephrotic. That has to be written first. Then mechanism of edema between a nephritic and nephrotic. Here it is due to sodium and water retention. Here due to decrease in plasma osmotic pressure. Then here hematuria will be very evident. Actually, hematuria will be minimal in nephrotic syndrome. It will not be completely absent, but minimal or rare hematuria can be there. Hypertension will be the most common evidence in the nephritic syndrome, whereas it will present in nephrotic syndrome, but it will be mild. Initial in acute phases, it will be usually mild. Then here the hyperlipidemia, lipiduria, all this will be absent in case of nephritic, whereas it will be present in case of nephrotic. And oliguria will be usually present in both the cases. Hypercoagulability will be more common with the nephrotic syndrome. So minimal change disease, I'm not going into details. Just go through once. Common in children's, unusual cause for the nephrotic syndrome in the children's. Main thing, there is no immune complexes. We cannot identify any immune complex by the DIF. And immune dysfunction is mainly due to cytokines or inflammatory mediators, which will be released due to some viral infections or the pertain to some bacterial infections. In some cases, there is a mutation in the glomerular proteins, that is nephrin. Then comes to the important topic, pyelonephritis. So you all know chronic pyelonephritis. Why it occurs is because of abnormal vesicular ureteric reflex, or it can be due to a chronic bacterial infection in short urethra in case of females, or it can be due to, or especially by the E. coli or the Proteus or the Klebsiella organisms, or sometimes in the immunocompromised patients, especially in the polyomavirus or a cytomegalovirus infection. And it is usually associated with urinary tract infections. So minimal change, this is most important. You can identify the abnormality not by the you cannot identify any kind of abnormality microscopically by HND. Only in case of electron microscopy, if it was done, it shows some abnormality in the abnormal deposition in the microvilli in the visceral epithelial cells, as well as some kind of food process abnormalities can be identified. That's all. And usually this patient will be highly respond to the corticosteroid therapies. So I have told you pyelonephritis. These are the ascending infections. Pyelonephritis can be classified into acute and chronic pyelonephritis. Chronic pyelonephritis, again, I think everywhere you will get a slide. Okay. In chronic pyelonephritis, microscopically, what you will see, glomerular sclerosis or glomerular damage will be there. Then with interstitial spaces shows lot of inflammatory infiltrate. Predominantly, it will be mixed inflammatory infiltrate, or it will be a mononuclear inflammatory infiltrate composed of lymphocytes and plasma cells. With the tubular atrophy or thyroidization of the tubules will be present. So this will be the usual pictures in the chronic pyelonephritis. Whereas in case of acute pyelonephritis, you will have lot of intratubular aggregates of neutrophils and tubular necrosis. And if you see in the capsule acids and the kidney acids, you will have a papillary necrosis, or sometimes you will have an abscess cavity will be there within the kidney, which will present as either a perinephric abscess or a pyelonephrosis. So this is a case of acute pyelonephritis, where the cortical surface you can see multiple abscess were seen, and you can see in the microscopy this is a diffuse infiltration of neutrophils within the tubules. Next will be the chronic pyelonephritis. I have told you all this thing. Glomerular sclerosis, fibrosis. See, the kidney is totally replaced as a non-functional some contracted kidney with a lot of scars were seen. V-shaped, U-shaped scars will be seen, which will be a non-functional with irregular depressions can be seen on the cortical surface. So whenever you are writing for the chronic pyelonephritis, it should contain what is the definition of chronic pyelonephritis. When you say it's a chronic pyelonephritis, what are the etiological factors? What are should be the risk factors? Grossly, how the kidney will appear. So the cortical surface, you can see multiple scars. V-shaped, U-shaped scars will be there with variable size on the cortical surface. And then contracted multiple scars on the surface will be there, which will be covered with the purulent material. Then dilated calyces. Sometimes it may contain some obstructive polyp or some kind of small malignant growth can be there, or sometimes there can be stones. And these stones specifically, it will be seen at the pelvic calyceal system, so they are called as staghorn stones. So this is a microscopy picture. I have told you this is a glomerulus, which is hyalinized, or sometimes you will see a sclerosed glomerulus. Tubules, you can see which thyroidization or colloid cast is be seen, and interstitial spaces were showing chronic inflammatory infiltrates. So next comes to the renal calculi. So till now we have seen acute pyelonephritis, nephritic syndrome, nephrotic syndrome, the difference between nephritic and nephrotic syndrome, then presentation of chronic pyelonephritis, both gross and the microscopy. Then comes to the renal calculi. Another important question in the kidney. Renal calculi most commonly it affects the men rather than the women. It is of familial and hereditary, and sometimes inborn errors of metabolism also identified in the calcium metabolism. It will be asymptomatic. Severe renal colic will be the usual presentation. Abdominal pain or sometimes hematuria or recurrent urinary tract infections. And you should be able to identify the types of calculi in the ultrasonography. Either it can be calcium stones or triple stones or uric acid or cystine stones. So calcium stones mainly usually in hypercalcium and hypercalciuria. Then triple phosphate usually occurs followed by the recurrent urinary tract infection by the urea splitting bacteria protease, and this will be the usually Staghorn calculi. Uric acid stone, hyperurism usually seen in the gout, which will lead to this uric acid stones. Sometimes it can be associated with leukemias and lymphomas, where there was increased turnover of the cell, which causes increased uric acid secretion. And also in cystine zone, mainly it's seen in cysturias, in genetic defects in the renal absorption of the proteins. And common sites will be renal calyces and pelvis. It can be single or multiple, or it can be at the branching of vesicular junction. So where you can able to see at the Staghorn calculi. So before going to the tumor, so the most common tumors in renal system, you all know will be your renal cell carcinoma. First, let me finish this Wilms tumor. Wilms tumor is commonly asked question, which is otherwise called as a nephroblastoma, commonly seen in children between 2 to 5 years of age group or below 10 years of age, which 10, 5 to 10% they say bilateral kidneys will be usually affected. Pathogenesis, if you see, it is usually associated with WAGR syndrome with the deletion on the chromosome 11, or Danish-Drash syndrome, or Beckwith-Whiteman syndrome, or there can be abnormality in the gene encoding beta-catenin. So grossly, this usually present as a large, solitary, well-circumscribed mass. It is by 10% will be bilateral, multicentric at the time of diagnosis. Cut section will be usually soft, homogeneous, tan to gray, and there can be foci of hemorrhages formation in the necrosis, which will also will give typically like a variegated appearance, which we will see in the renal cell carcinoma. So here, microscopically, you know, blastomal elements, triphasic combination of blastomal, stromal, and epithelium will be epithelial cells will be observed in majority of the lesion. You all know here these are the undifferentiated cells which are called as blastomal cells, and these are the stromal cells or the spindle cell fibroblast, or sometimes it can be an vascular endothelial cells, and these are the epithelial cells which appears as a glandular or acinar pattern. So all three these components, blastomal component, epithelial component, and the stromal cells, which can be either a fibroblast or it can be skeletal muscle differentiation, but it is very rare to have, or sometimes myxoid in nature. So you have to see all this triphasic component to before you test them as a Wilms tumor. So this is about the Wilms tumor, and it's usually diagnosed on the ultrasound with the non-functioning kidney, with the growth will be there, and nephrectomy will be usually received. So next comes to this cystic disease of the kidney. Another important short notes will be the cystic disease of the kidney. We have a list of cystic disease of the kidney, but I'm not going into the all this thing. Most commonly will be the polycystic kidney disease, which you have to know, adult dominant, or it can be autosomal recessive childhood polycystic kidney diseases. So these are the different types of cysts in the kidney. Here, this is a normal kidney where we have not seen no cyst. This is a simple cyst which you usually seen on the cortex, involving the cortex or the capsule, which does not relate to any kind of functional abnormality with the kidney. So this is a recessive polycystic, autosomal recessive polycystic kidneys, where cysts will be more common in the medullary areas, and the cortex will be usually normal, or sometimes it will be dilated. So that will lead to enlarged kidney. And this is a dominant polycystic kidneys where you cannot see a normal parenchyma. The complete parenchyma will be replaced by the multiple cysts. And the down will be the cyst which involve the part of the kidney, but this is a dysplastic cyst associated with certain kind of dysplasia will be there in the cortex and the cortex medullary areas. So this is a medullary sponge cystic disease kidney, involves your pelvic junction. So here again we have a 2 or 3 types are there. Cyst involving the complete pyramids or completely replaced by an abnormal dysplastic kidney. So these are the differences usually it will be seen in the renal system. So these are the autosomal dominant kidney. As I told you, you cannot be able to see the normal parenchyma at all. It will be completely replaced by multiple cysts. You can't say this is actually kidney at all. So one of the most common this thing, and it is usually associated adult dominant autosomal dominant polycystic kidney disease. This is it was associated with cystic fibrosis or with the sickle cell disease. Here, actually, from in utero itself, the complete nephron will be replaced by the multiple cysts. And there are two genes which are responsible for this polycystic kidney disease. Their mutation will be usually polycystin 1 or polycystin 2, which plays an important role in the proliferation and the differentiation, which will be usually mutated because of this. So, what are the difference? PKD1 is the common mutation in autosomal dominant, and this is distal nephrons will be commonly affected, whereas PKD2, all parts, even the extrarenal tissues, also will show cystic degeneration. I have given you the picture depiction how this polycystin 1 and 2 will be involved in the cellular proliferation by modifying the calcium levels. So this is completely replacement by the cyst. Microscopically, you can see in between some glomerulus are there, but this glomerulus will be usually a sclerosed glomeruli, does not have any function at all. Otherwise, other renal parenchymas will be totally replaced by the cyst, which will be lined by thin wall with the flattened lining epithelium, with intervening stroma shows lot of inflammatory infiltrate. So they present as an hematuria, or sometimes they present with a full-blown picture of chronic kidney disease. In children's, 40% will be most common for the chronic kidney disease will be the autosomal dominant polycystic kidney disease. In adults, it is about 60%, and they usually present with renal failure before the age of 60 years. Sorry, they may associate with cyst in the other organs, extrarenal manifestations such as pancreas, liver, gastrointestinal tract, this is called colonic diverticulite, or may be associated with cerebral vascular aneurysm or the mitral valve prolapse syndromes. So this is about the autosomal dominant. Next comes to the autosomal recessive. Here I told you autosomal recessive. Again, it can be involves only the medullary areas. So again here the gene mutation will be the PKHD1. So its product will be usually a fibrocystin polydictin. This involved in the cellular proliferation and the cell addition. At least you remember these things so that you can able to write the pathogenesis. So the surface will be usually uniform and it will be more glistening on appearance with multiple equal size rounded cysts will be there on the capsule. So here you can see the complete replacement of this medullary area by the lot of cystic walled cyst. Okay. I think this is enough. Other medullary cysts, you should know what are the medullary MCQs. They can ask you what are the medullary cysts will be most commonly present. Will be usually medullary sponge kidney, or it can be a medullary cystic complex disease. I'm not going detail into that because of time. This thing we'll go ahead with the other things. The last cyst important cyst will be the acquired renal cystic disease, which will be usually associated with malignancies, and or sometimes this cyst which occurs because of recurrent infections or chronic pyelonephritis, which will lead to this acquired renal cystic disease. They are more prone to develop your renal cell carcinomas. So simple cyst can be only I have told you previously, this is only a retention cyst in the cortex, which will be usually asymptomatic, does not going to affect any kind of your renal function. So that will be the simple cyst. Okay. So with this, I think all the important questions of your renal system I have covered. So first will be the acute acute glomerulonephritis. Then we talked about nephrotic syndrome, the difference between nephritic and nephrotic syndrome. Then we talked about acute pyelonephritis. How do they usually present? Then chronic pyelonephritis. What could be the cross and the microscopy? Then we talked about the Bill's tumor. Then the most important thing I forgot to tell you will be the renal cell carcinoma. As you all know, renal cell carcinoma is the most common tumor in the adult. Among all the variants, clear cell carcinoma is the usual common variant. Just a moment. I think I have kept some slides over there. Okay. I forgot to include in the slides. So clear cell carcinoma will be the most common, which is associated with moderate prognosis of the tumor. So grossly, the tumor can be there in the either in the upper pole or the lower pole. It is usually a single tumor, or it can be multicentric involving multiple poles, or it can involve the pelvic junction, and cut section of the tumor usually will have an variegated appearance with multiple degenerations like hemorrhage, necrosis, cyst, and other formations can be there. And it usually spreads via your renal vein into inferior vena cava. Hematogenous spread will be the more common in the renal cell carcinoma. And microscopically, clear cell carcinoma is the usual common variant. Then comes to your chromophobe, and then papillary renal cell carcinoma, oppositic variant, and the other variants. Okay, I think with this we'll complete our kidney. We'll go ahead with your male genital tract system. So in male genital tract system, most commonly we used to get questions from your testicular tumors, or it can be from the BPH, or it can be from the carcinoma of the prostate. I think BPH and the carcinoma of the prostate will be most common asked question in your 5 marks. And then 2-mark question, or sometimes this has also been asked in your MCQs about the cryptorchidism. Then another 5-mark, important 5-mark question will be a premalignant lesions of the penis. So first, non-neoplastic lesion, most common will be the cryptorchidism. As you all know, it is an undescended testis. Or sometimes we will see the fused testis, very rare, less than 1%, which is called as in synorchism. Cryptorchidism, what will happen? There can be arrest in the maturation of the germ cells will be there, because it has not been descended to the scrotal sac. It's either present in the under the flow of descent. It can be at any places. Most commonly, it was been identified within the abdomen, which will lead to the further development of intertubular germ cell neoplasia or to the germ cell tumors of the testis. One of the important cause. Okay. So here you can see this is a cryptorchid testis. This is a normal maturation of the testicular tubules with your primordial spermatogonia to the mature sperms. Here you can see, able to see, it was an arrest in the spermatogenesis, which you can see. And also there is a basement membrane thickening. And sometimes you have, these are all actually complete atrophy of the seminiferous tubules are there. So that is all possible with the cryptorchidism microscopy. So complication is, you all know, it is usually sterility. Malignancy will be the most common. And they are more prone for the trauma, especially in the inguinal testis. And then surgical correction below 2 years will be usually advisable. So it may be associated with other abnormalities, genitourinary tract abnormalities, and hyposperiosis is also most common. The other important benign lesions of the testis will be your torsion. Then comes to the granulomatous arthritis. Granulomatous epididymitis is most common tuberculosis infection in the Indian population. Here, the granulomas will be either confined to only to the epidermis or to the seminiferous tubules. Okay, so this is, here you can see this is the granulomatous arthritis of the testis. Here you can see they are the necrosis with the granulomas. The other important cause for the granulomatous arthritis will be your syphilis, but it is very rare nowadays. So neoplastic, the common classification of testicular tumors, either classified into seminimatous tumor or non-seminimatous tumor, and then sex cord stromal tumor. Seminomatous, we know seminomas and spermatocytic seminomas. Non-seminomatous will be embryonal yolk sac, choriocarcinomas, and teratomas. Sex cord stromal tumors will be either Leydig or the Sertoli cell tumors. Pathogenesis, as I told previously, cryptorchidism is the most common cause for the development of testicular tumors. And then testicular dysgenesis syndrome, such as Klinefelter or the feminization syndromes, are also one of the cause to develop testicular tumors. And it occurs in the family. Clusterings are all been identified. Genetic factors are also involved. Seminoma is the most common germ cell tumors, usually occurs in the peaks of 30. Classical type, these are the previous classification. Nowadays, it has been classified into either a spermatocytic type or the seminomas. That's all, classical type. We don't have an, nowadays we have only classical type and the anaplastic. We don't have a spermatocytic type. That has been removed from the pathological classification. So, spermatocytic seminoma, they say metastasis will be very rare in the spermatocytic seminoma and it will have an excellent prognosis. So here you can see gross picture of a testis with the growth, which is a well-defined gray-white tumor. On even cut section, it shows an homogeneous gray-white tumor. Flesh-like appearance will be there. Seminomas. And here you can see multiple, actually it will be a multiple lobules of tumor or the tumor nest with polygonal round-shaped cells with clear cytoplasm, pleomorphic nucleus, and sometimes prominent nucleoli. This is a counterpart of your dysgeminoma in the ovaries. Okay. So special features in spermatocytic is, and each lobules or each nodules will be separated by the fibrous stroma, and the fibrous stroma will contain lot of lymphoplasmacytic infiltration will be there. Whereas in a spermatocytic seminoma, they say they contain lot of giant cells within them. And most important thing about the spermatocytic seminoma, what they said is, it will never metastasis. Whereas classical seminoma has a tendency to have a lymph node metastasis. And it will have a very good prognosis. So this is the case of spermatocytic seminoma. Then you have an anaplastic seminoma where the tumor cells will be bizarre cells with highly pleomorphic nucleus and prominent nucleoli will be there. Next important tumor in the germ cell tumors of the testis will be your embryonal carcinoma. This embryonal carcinoma will occur lesser than the age of the seminoma. If seminomas are common in 30 years, embryonal carcinomas are more common less than 30 years. And again, this will also have a variegated appearance, whereas seminoma will have a fish flesh-like appearance, which is an homogeneous gray-white tumor. And histologically, we have a different patterns in case of embryonal carcinoma, with lot of necrosis will be there. Here you will have alveolar pattern, tubular pattern, and then papillary pattern of arrangement of tumor cells. And one more thing, tumor cells will be very small and minimal, smaller tumor cells compared to the seminomatous cells. And cytoplasm will be very minimal in case of embryonal carcinoma, undifferentiated cells. That's what it was called as an embryonal carcinoma. But the seminoma will have a clear cytoplasm and then pleomorphic nucleus and the prominent nucleoli. As similar to your ovary, testis also will have a teratomas. You can have, again you have a, the three types of teratomas are also common in testis: mature, immature, and specialized teratomas are very rare in testis as compared to the ovaries. So here teratomas are usually cystic in case of mature teratomas. Immature teratomas can be partly cystic and partly solid, and you will have a differentiation of all three germ layers, and the products of all three germ layers will be seen. If you see in mature elements, you call them as a mature teratoma. Again, the most common age group will be less than 10 years, so less than 20 years, or between 15 to 20 years will be the most common age group for the teratomas. And the next important tumor will be your yolk sac tumor. Yolk sac tumor, as like your ovary, highly malignant tumor will be a yolk sac tumor, which is going to have a very bad prognosis compared to all other tumors in the germ cell tumors of testis. And germ cell tumors are common less than 10 years of old of children. And It usually occurs in combination with other germ cell tumors rather than it occurs purely yolk sac. So yolk sac tumor is otherwise called as endodermal sinus tumor. Another important tumor when testis is compared is testicular lymphoma. So we have seen nowadays, rather than seminomas, nowadays we are seeing lot of testicular lymphomas. Diffuse large B-cell lymphoma, non-Hodgkin's lymphoma is the commonest tumor. Commonest testicular lymphoma is usually observed, which will also have a very bad prognosis. Another important thing is difference between your seminoma versus non-seminomatous germ cell tumor. So here you can see it is more likely to be, it never metastasis. It's very rare to have metastasis of seminomas. But here non-seminomatous germ cell tumor usually will metastasis. This will be usually radio sensitive. So radiotherapy will be usually very effective. It is not radio sensitive tumor. Tumor markers will be usually less useful. Sometimes AFP will be elevated. Alkaline fetoproteins will be elevated. Here, tumor markers are more useful and it is more likely to have a hematogenous spread. This will very rarely to have this spread. So these are the usual markers. HCG, yolk sac tumors, alpha fetoproteins can be there in the seminomas or in the yolk sac. And then choriocarcinoma, gestational choriocarcinomas will have an HCG, and then plaque will be usually done to differentiate the tumors. So this is up to testis. When it comes to the penis, penile squamous cell carcinoma, everybody knows squamous cell carcinoma will be the commonest tumor. But we have to know about the pre-malignant lesions. So revise about the pre-malignant lesions such as condyloma acuminata, Bowen's disease, and Bovanoid papulosis. So all these are usually an HPV associated disorder, which will show such changes like dysplasias and then carcinomas in situ. Only by the clinical presentation, they have a different kinds of names there. So the most common warty growth. If the history was given as a warty growth who's been a sexually active male, which can be single or multiple sessile vacuolated pedunculated growth, and you can diagnose them as condyloma acuminata. These were the usual common histories which has been given, and it is associated with HPV infection like 6 and 11. And giant condylomas, this is an usual MCQ question, is called as a Buschke-Lowenstein's tumor. So this is a warty growth seen in the glans penis, and you can see acanthosis and hyperkeratosis with a lot of, I'm sorry, I'm having a very bad picture. Coilocytic ATPS will be more common. I couldn't able to show the coilocytosis. What is coilocytosis? Perinuclear clearing of squamous cells. Okay, and it will be regular with atypia. Condensed nucleus will be seen. You all know squamous will have a good nuclear cytoplasmic ratio will be usually maintained in the squamous cells. Here actually the nuclear size will be usually condensed, and that is called as an atypical coilocytic atypia, which will be seen. In the dermoepidermal junction, you can see a lot of inflammatory infiltrate will be seen. And this inflammatory infiltrate predominantly composed of lymphocytes. And you can see this warty growth pattern. Okay, filiform warty growth pattern will be seen with acanthosis and all this thing. Next will be the Bowen's disease. As I told you, again, this is also associated with your HPV infection. Main thing is here acanthosis will be there, hyperkeratosis will be less, and this will be usually appears as a plaque. Whereas condyloma acuminata will be a warty growth. Okay, plaque with shallow ulceration will be more common features. And when you see microscopically, you will see a mild to moderate dysplasia will be there. And mitosis with acanthosis will be the most common. Dermoepidermal duction, again, it is well demarcated in the Bowen's disease. Another important pre-malignant lesion will be nephroplasia of Poirot. It's similar to Bowen's. Only one thing is, it is a clinical variant, and this will appear as a red velvety plaque. Next will be the Bovanoid papulosis. Bovanoid papulosis, till then this Bowen's disease, condyloma acuminata and erythroplasia puret will be usually associated with HPV of 6 and 11, and this is usually associated with HPV 16. This will be a raised reddish papular lesion. So here you can see multiple papillary lesions are there, raised lesion. The difference between a carcinoma in situ and papillosis is main thing is in carcinoma in situ, this full thickness of dysplasia will be seen here. Whereas in papillosis, bone and papillosis, it will be moderate dysplasia. That's all. There is no associated any other malignancy. Visceral malignancy will not be identified with the case of bone and papillosis, but here in bones, it is associated with the risk of malignancies. And this is also with carcinoma of HPV. Both are associated with carcinoma of HPV 16. But once this is along with HPV 16, you can able to see other HPVs also. Then comes to this squamous cell carcinoma. You all know the three important patterns of squamous cell carcinoma will be either ulcer, or it can be an ulcero-infiltrative lesion. It can be endophytic or exophytic type of growth will be there. So here ulcero-infiltrative growth in the glans penis you can able to see here. And what will be the typical description in this squamous cell carcinoma? The tumor will be arises from the dysplastic epithelium with or without ulceration, with a downward proliferation, and proliferated as a lobules, multiple lobules or the nest of tumor cells will be infiltrating the underlying subepithelial tissue, and they appears as multiple nests which will be separated by a fibrous stroma, and stroma will shows a lot of inflammatory infiltrate. Lymphocytic infiltration will be there. With, if you go on to see individual cells, you can see it is a polygonal shaped cells with deeply eosinophilic cytoplasm, pleomorphic nucleus and prominent pleomorphic nucleus, hyperchromatic to vesicular chromatin and prominent nucleoli. With individual cell dyskeratosis, loss of cellular bridges will be there, and lot of keratin flakes will be there. Or you can say, you can able to identify this keratin. Okay, this keratin flakes will be usually identified. So depending upon the differentiation, they are being differentiated into well differentiated, modern differentiated, and poorly differentiated. And carcinoma of penis usually will metastasis via the lymph node. Inguinal lymph node will be the usual sentinel nodes for the carcinoma of the penis. So this is about the penis. Penis we have seen pre-malignant lesions and the carcinoma of the penis. Then comes to the prostate. Prostate, you know, the typical two important lesions will be the benign prostatic hyperplasia and the prostatic adenocarcinoma. As such, prostatic adenoma, both of them, the most important picture which you have to concentrate will be your pathogenesis rather than the other things. And Gleason scoring for the prostatic adenocarcinoma is a usual short answer question. We'll see them. So the significant by the age of 40 years, usually they present with urinary retention, or there can be other symptoms of urinary obstructions will be there in case of BPH. And BPH, what will be the usually top specimen, transgurethral resection specimens only will be receiving in the pathology. And when you see the BPH, usually it shows what is the BPH? It's a benign prostatic hyperplasia. So it can be an hyperplasia of glans, or it can be hyperplasia of the stroma. So prostate, the lining epithelium will be, if it is from the transitional urethra, you will have a transitional epithelium. Otherwise, it will be a flattened epithelium composed of glands and the stroma. So you will see glandular proliferation as well as stromal proliferation. Sometimes you will see only a stromal proliferation, then you have to call them a stromal tumor of the prostate. That is a different entity. We leave them. But usually BPH will have a combined proliferation of both the glands and the stroma will be there. Fibromuscular stroma will be hyperplastic. And the glands will be usually lined by the tall columnar epithelial cells with the flattened myoepithelial cells. Since they are endocrine organ, so we'll have both glandular as well as myoepithelial component. See, it's a autopsy specimen of BPH which was showing multiple nodules on the gross. So this is the prostate which shows a multiple nodular hyperplasia. See here the same thing. I have told you glands will be proliferating. So when they start proliferating, they have been converted into multiple cystic spaces. So it's a glandular cystic spaces which will line by the columnar epithelial cells, And in between the stroma will show mild lymphocytic infiltration, which is common with all kinds of hyperplasia, which is surrounded by this fibrous stroma, fibromuscular stroma, which has been proliferated. This is the duct which has been proliferated. Then the most common will be the carcinoma of the prostate. So carcinoma of the prostate, nothing but it's an adenocarcinoma. So here what will happen? The glands, I've told you in BPA, the glands will be dilated, cystically dilated. Here the glands will be usually small glands, which will be lined by the single uniform cuboidal to low columnar epithelial cells. The most important picture to differentiate the carcinoma of the prostate from the benign will be a lack of myoepithelial layer. Here, myoepithelial layer will be completely absent. Okay. And malignant glands will be crowded each other. So next important thing which I have told is Gleason scoring. See here we have seen the Gleason scoring of 2 to 4. When you see actually all tumor has a primary scoring and a secondary scoring. So we call them as girl scoring and the boy scoring. So primary scoring will be the major part of the tumor in your biopsy, which will be scored between this 2 to 10. And then minor scoring will be the minimal part of the scoring which is given to the tumor. So we have to add up both of them, will get the complementary score, and that will be given for the grade of the tumor. Okay. So there is no other way. You have to mug up. Remember, 2 to 4 will be small glands, will be closely packed. It should be usually well differentiated glands. Whereas 5 to 6 will be moderate differentiated with a minimal stroma. Cribriform pattern of glands will be seen, sometimes with the necrosis. That will be the most common with the Gleason score of 5 to 6. 7 will be usually polar differentiated tumor. Nest of tumor cells will be there, and with the necrosis will be the most common. 8 to 10, again, it's going to be a very polar differentiated tumor, which will show us actually lymphovascular invasion as well as a perineural invasion. And it is a more aggressive type. Okay. So this is a case of adenocarcinoma of the tumor where you can able to see lot of necrosis and hemorrhage will be seen. So here you can see these are the malignant glands with the back-to-back arrangement and complete absence of myoepithelial layer. You are not able to see this myoepithelial layer. And these are the pleomorphic cells which are lining dark cytoplasm with prominent nucleoli, you can able to see. And there is some kind of necrosis within which is filling up the glands. So this is about your kidney and the MGT. Next comes to the FGT. FGT, you all know, most commonly it's the questions are from ovaries, cervix. Long question I'm saying. See, as per second paper is considered, the most common long question will be from your systemic part. Long questions will be from usually the part 2 will be from either it can be from the kidney or sometimes it can be from your FGTs, either from the ovary or from the cervix or sometimes from the endometrium, or else they can ask very rarely. This BPH can be asked straightforward question. BPH can be asked in your long question, or sometimes bone tumors or your breast malignancies. Very rarely osteosarcomas can be asked in your long question. So in FGTs, as per FGTs concerned, ovary will be the most common long question. Then comes to your endometrium and the cervix. So as you all know, you have to know your ovarian tumor classification. So as per um, a broader classification, so the tumors can be from the surface epithelium, or it can be from the germ cells, or it can be from the sex cord stromal tumors. Okay. So surface epithelium, again it is subclassified into serous, mucinous, endometrioid, and then clear cell. Then in germ cell, as typically what we saw in testis, you have an dysseminomas, which is the counterpart of the seminoma, yolk sac, embryonal carcinoma, choriocarcinoma, and then this is a non-gestational choriocarcinoma, teratomas, and mixed germ cell tumors are more common in the ovaries. And then we have a sex called stromal tumors such as granulosa cell tumor, fibroma thicoma, or certainly Leydig cell tumor, and very rarely gorodoblastomas. Okay. This is a broad overview of the classification. Classification of ovarian tumor is very important. Okay. Then comes to your, so whenever a ovarian tumor was asked, either it can be a serous tumor or it can be a mucinous or endometriotic, anything else. Start with your risk factors. That is very important. So what are the important risk factors? As per the ovarian tumor are considered will be gonadal dysgenesis, nulliparity, family history, associated with the BRCA gene mutation or any tumor suppressor gene mutation which can be associated with the breast as well as with the ovary or sometimes with the endometrium. Then I'm not going into the non-functional. So the major difference which you have to note down between in the history, so to come into the conclusion whether it could be serous or the mucinous will be, if they've given it is a bilateral tumor and it is an ovarian imaging was given, so it is a multiple cystic and solid tumor. Okay. So listen to me, cystic and solid tumor and bilateral ovarian tumor. The most common thing which you have to think about will be a serous. And uneven, the cyst walls are thick wall separated by thick gelatinous material, then you have to think about mucinous. If it is a clear serous fluid, then you have to think about only the serous tumor. If it is a bilateral solid tumor, the first differential you have to think about will be your cucumbers. Metastatic tumor from the other areas, especially from the breast and the GI. Okay. So, before going to the epithelial tumor, again this serous tumors or the mucinous tumor. Every epithelial tumors are classified into three categories: benign, intermediate, or a borderline, or it can be classified into malignant. Okay. So, first we'll see into the serous tumor. So serous will contain a clear fluid and often it occurs in the perimenopausal or the postmenopausal age group. I've been classified into benign, borderline and the malignant. So as I told you, benign will be usually cystic, completely cystic, occurs in the reproductive age group or sometimes in the perimenopausal age group. Small papulas can be present on the cyst wall, but there should not be any kind of nuclear atypia or invagination of the stromal invasion. Whereas borderline, so this is an example of serous cyst adenoma, benign serous cyst. You can see a thin walled cyst with multiple clear spaces in the hemorrhage areas were seen. See, this is a cyst which is lined by the columnar lining epithelium. Here again is cystic spaces which are lined by the columnar epithelium with stroma. This is an ovarian stroma. Here you can see this is thin wall, single layer of lining of columnar epithelium will be seen. Then comes to the borderline tumor. Borderline can be again cystic and solid. But the solid area predominantly will show this kind of papillary structures, multiple papillary structures. And you can see there can be a micropapillary invaginations. So this is a borderline papillary serous cyst adenoma. Multiple papillary invaginations into the underlying stroma, which may show usually microinvasive pattern. But this invasion should not go more than 5 mm vertically oriented within the ovarian stroma. And the nuclear atypia also. Stratification can be up to 2 to 4 layers. In case of intermediate tumors, both in the serous as well as in the mucinous. And nuclear polymorphism will be mild to moderate nuclear atypia will be present usually, but not an highly malignant nuclear atypia or an atypical mitosis or the areas of necrosis will not be present in case of borderline tumors. And one more thing, the invagination should be within the cyst wall and not into the underlying stroma. So this is an adenocarcinoma. This is actually serous cyst adenocarcinoma, which is a fleshy tumor, okay, which is a gray-white. This will also show with areas of hemorrhage and necrosis. See here, these are the tumor cells. They are actually adenocarcinoma. It's similar to your adenocarcinoma, usually papillary adenocarcinoma. All papillary adenocarcinoma, wherever it was present, will show you the dystrophic calcification, which is called as symbiosis. So that will also will gives you clue this is a malignant. Okay. See here also you can see this calcification. It's not typically looks like a small body, but calcification is present. And this is completely stroma. The stroma is showing a tumor invasion. These are the tumor cells. As I told you, it is the polyrefractory adenocarcinoma. These are the glandular arrangement. Okay, and sheets of tumor cells which are invaginating or present within the cyst wall. Okay. Next comes to the mucinous tumor. One of the most important complications of the mucinous tumor will be a pseudomyxoma peritoneum. So this is mucinous adenoma. This is an borderline tumor. See here, you can see the invagination, but not within the tumor, not within the papillary spaces. What are the two types of mucinous lining epithelium which usually will get in the ovary? One is endocervical type, another one is intestinal type of mucinous epithelium. Will be more common. So next will be the mucinous cystadenocarcinoma. Again, mucinous cystadenocarcinoma can be partly cystic and partly solid. Predominantly it will be solid. So here you can see sheets of tumor cells and it will be typically mimic like your colonic mucinous adenocarcinoma, which will have both extracellular mucin and intercellular mucin droplets. Okay. See here just to show you the difference between a cyst, borderline tumor, and it is a malignant adenocarcinoma. Next comes to the endometrioid. Endometrial will be similar to your endometrial carcinoma. Okay, which will be present. So it is a gland. One more important thing is mostly 99% endometrial tumors will be fleshy tumors. So it will be a solid tumors. And the size will be less than that of serous and the mucinous. Grossly also we can able to identify the endometrial tumors. See this glands are look similar to your endometrial glands. Next comes to the Brennus tumor. In a few question paper, they have asked actually the Brennus tumor. Again, Brennus can be benign, borderline Brenner, and malignant. It is nothing but transitional epithelium. This is a benign Brenner tumor. See, this is the fibroblastic stroma. Within the stroma, you can see the nest of transitional epithelium. So this is a classical picture of your benign Brenner. And next will be this epithelium will be thrown as like your papillary fronts, which you will see in the transitional cell papilloma in the bladder. This is a case of borderline Brenner tumor. Same thing. When it becomes a malignant, it is a transitional cell carcinoma, which usually be seen in the bladder. Okay. With high mitosis, high atypical figures will be there. Apoptosis will be more common and necrosis. Okay. Clear cell carcinoma, again, it is going to be a very bad prognosis. The most important thing is hobnailing pattern will be seen. It will be a nest of tumor. You can see hobnailing of secretion will be more common with the clear cell carcinoma with cystic and nationalist clear cell spaces. So this is about the epithelial tumor of the ovary. Then comes to the germ cell tumor. You all know very well about the teratoma. Most commonly, mature teratomas will have a differentiation of all germ cell layers. Remnants will be present over there. Here you can see the sebaceous metal sebum is coming out and tuft of hair follicles. So microscopically you can able to see stratified squamous epithelium, pilosebaceous unit. You can see able to see matured cartilage. You can able to see matured retinas and then other mature elements. Lipomatous tissue, mucinous glands, intestinal mucinous glands, or GI tract epithelium or respiratory tract epithelium, anything can be seen within the tumor. Then you call them as a mature teratoma. Then comes to the immature teratoma. Immature elements of the germ cell with an immature differentiation is called as an immature teratoma. Here you can able to see choroid plexus. Okay, with an immature neuroglial tissues are more common. And then malignant teratomas, they'll have a transformation to any kind of epithelium into malignancy. For example, squamous cell carcinoma or an adenocarcinoma can be present within the mature teratoma is also possible or completely replace the mature teratoma. The another important entity with the teratoma will be your monodermal or the specialized teratomas, which can be struma ovary or it can be a carcinoid tumor. So next will be the yolk sac. Again, it is an endodermal sinus tumor. Most common what you will see will be your Schiller dual bodies, which will be around your blood vessel. Tumor cells arranged around the blood vessels are called as an Schiller dual bodies. Next comes to the Dysseminoma, which is a counterpart of seminomas. As I told you, we see large polygonal shells with clear cell cytoplasm and an abnormal irregular nuclear membrane and prominent nucleus of will be there, which will be arranged in the lobules, and lobules will be separated by the thin stroma with the inflammatory infiltrate. Granulosa theca cell and the granulosa cell tumor, most common thing would be they are the estrogen producing tumor. So they usually seen in the reproductive age group or the perimenopausal age group with a typical clinical picture of AUB or endometrial hyperplasia will be there. Here microscopically you can able to see coffee bean appearance of the nucleus, which can arrange in different patterns. Can be sinus pattern or it can be a water silky pattern. Any kind of glandular nest, trabeculus, anything can be there. Pattern of arrangement of the tumor cells. So granulosa, they can give you typical history of perimenopausal age group with abnormal uterine bleeding with single ovarian tumor which can be partly cystic and solid. Then comes to your Krukenberg's, which is a metastatic tumor, usually arises from the GIT, from the stomach or the colon, or it can be from the breast. So this is a mucinous adenocarcinoma which are infiltrating the ovaries and the peritoneum. These were the complication of the ovarian tumor. Figo staging. Remember, you have to read about the Figo staging of endometrium, ovary, as well as the cervix. Then comes to myometrium. Myometrial lesion, you all very well known that leiomyoma is a common tumor benign neoplasm which usually occurs in the myometrium. And this leiomyomas or again a estrogen dependent tumor, it will have lot of degenerations. Most common degeneration will be your hyalinization. And then leiomyomas are grossly, they have been classified into, depending upon the site, either they will present on the cervix, which is called a cervical leiomyoma, or within the body, it can be intramural, or it can be subserosal, or it can be a submucosal. See, this is a pedunculated leiomyoma, submucosal within the endometrial cavity, subserosal will be the outer serosal layer, or this is an pedunculated subserosal, and this is an intramural leiomyoma. And capsule cut section will specifically shows burled pattern, nothing but your smooth muscle bundles arranged in the burled format. Okay. So this is a gross appearance, which is a fish flesh-like appearance. On cut section can be gritty due to calcification or an hyalinization. So what will happen? Microscopically, specifically you have to write, it is a bundles and fascicles of smooth muscles, smooth muscle bundles with areas of fibrosis, calcification and the other degeneration. Here you can able to see hyalinizations are more common. Here are the interlacing fascicles and the bundles of pill-shaped smooth muscle cells. So one more thing, the wandering on the parasitic fibroid, which is usually have a pedicle which may get detached, and with the nourishment of the omental or the mesenteric adhesions will be most common with this. Other will be the cervical fibroid. Any fibroid can undergo a lot of secondary changes. I have told you there can be atrophy, there can be necrosis, or there can be vascular changes, or sometimes you can have a sarcomatous degeneration. And another important, the malignant counterpart of the leiomyoma will be called as a leiomyosarcoma. It is a soft, fleshy tumor which will have an hemorrhagic areas. The most important thing about your leiomyosarcoma will be your nuclear atypia, pleomorphism, mitosis, and the areas of necrosis. All leiomyomas can have hemorrhagic necrosis. That necrosis cannot be considered as a necrosis for the necrosis component for your leiomyosarcoma. Leiomyosarcoma should show an coagulative necrosis. An atypical mitosis will depends upon the places where the leiomyosarcoma has been usually diagnosed. In uterus, this is more than 10 to 20% hypophil will be considered as significant for the to diagnose the leiomyosarcoma of the uterus. Other things you all know, adenomyosis and endometriosis. Presence of normal endometrial glands within the myometrium is called as an adenomyosis. Endometriosis outside the uterus is called as an endometriosis. In both of these cases, usually they present clinically as dysmenorrhagia and pelvic pain and menorrhagia. That will be the most common. And adenomyosis, you will have uneven thickness of myometrium will be there with gray-black trabecular areas. You can able to see this trabecular areas. These are the gray-black coarse trabeculation will be seen. Usually will be gives rise to adenomyosis. So within the normal myometrium, there is the presence of endometrial glands. Then comes to the gestational trophoblastic disease. So most important for you people, gestational trophoblastic, you have to know whether it is a partial mole, complete mole, and then a choriocarcinoma. I'm not going to touch into the other thing. Partial mole, depending upon complete mole and partial mole, depending upon your karyotyping, maternal chromosomal karyotyping only you can able to classify them as complete or adeniform mole. Complete mole, no fetal parts will be identified. Here, 23X chromosome will be fertilized by the single ova, empty ova. So naturally, we'll get 46XX. That is paternal chromosome alone will be duplicated. So it will be a homozygous in the 90%, which leads to androgenesis. So here, it is the heterozygous in the 10%. Then comes to your partial heteroform mole. So here what will happen? Empty egg which will be fertilized by the 23Y chromosome. That will lead to extra pairs of chromosome. So triploid 69XXY cell will be common in case of partial heteroform mole, where you are going to have a partial fetal protection will be there, but it is inevitable to continue. So there will be usually missed abortion to be most common with your incomplete and deformed mole. So how do they grossly present? They present as a multiple fluid-filled vesicles will be there along with your product of conception. In case of complete mole, no fetal or embryonic tissue will be identified. The completely present tissue will be replaced by the multiple grape-like vesicles. That will be in case of complete mole. So it is then microscopically, if you see, edematous villi with abnormal trophoblastic proliferation will be there. No fetal tissue or RBC will be identified within them. So here you can see the chorionic villi will be completely replaced by multiple fluid-filled vesicles or a grape-like a vesicles. So here it's all. This is the normal term placenta where you can able to see this blood vessels. Non-edematous villi. Here if you see the complete edematous villi, you can't see any vascular proliferation within the villi. And villi is also enlarged and there is irregular proliferation of trophoblastic on the surface can be seen, identified. So partial mole, again I told you, microscopically you will have an hydropic villi, combination of both hydropic villi as well as normal villi, minimal syncytial trophoblastic hyperplast, and there can be an enlarged cavitated villi will be more common. See here you can able to see some fetal tissue associated with the placenta will be completely replaced by the fluid-filled vesicles. So this is a picture of partial mole. So normal trophoblastic proliferation and then edematous villi. The difference between partial mole and complete mole, it's very, very important. So main thing you have to say, karyotyping differentiation between them and villus edema, how it will be there. Trophoblastic proliferation will be circumferential in case of complete mole. Here will be here and there focally. And then ATP will be usually often present in case of complete mole, which will be absent in the partial mole. HCG will be highly elevated in complete mole, which will be minimal elevated in the partial mole, but it is higher than that of your normal pregnancy. And it will be easily identified in the ultrasound abdomen, and partial mole usually present as a missed abortion. And then choriocarcinoma complication will be more common with your complete mole rather than your partial mole. Okay. Chorioedema distance and all I'm not going to. Next will come to your choriocarcinoma. So what are the risk factor for development of choriocarcinoma? That is very important. Recurrent premolar pregnancies and then abortions, bad obstetric histories, ectopic pregnancy, or it can be associated with other germ cell tumors in the ovary. So macroscopically, what will you see will be, it's a soft, fleshy yellow tumor which is seen within the uterine cavity with a lot of ischemic necrosis and other extensive hemorrhage will be there. Microscopically, you will see an solid masses or nest of malignant trophoblast cells with hemorrhage and necrosis with the presence of lymphovascular invasion, psychological atypia, and numerous mitotic figures will be seen. See here the uterine cavity which is sagittal section, shows hemorrhagic necrotic mass within the uterine cavity, infiltrating the whole cavity and totally distorting the uterine cavity. And it was extending even up to the cervical canal. See, these are the abnormal cytotrophoblast with cytological atypia and then intermediate trophoblast. So it is a highly malignant tumor and usually will metastasis to the lungs, GIT, lungs, liver, as well as to the bone, or sometimes to the CNS. DIs is also more common with these cases. So this is about your gestational trophoblastic disease and then ovary. Then comes to the cervical cancer. I think cervical cancer, not much. It's again a squamous cell carcinoma. But what are the pre-malignant lesion? How do you classify them as? CIN 1, 2, and 3. Now it has been replaced into low-grade dysplasia and the high-grade dysplasia. You should know about the pap smearing, how it is helpful in differentiating. Then bacillus system of pap smear reporting is also very important. How do they differentiate the mild, moderate, low-grade dysplasia and the high-grade dysplasia? What are the features of atypical squamous cells of undetermined significance? These all things are very important. Then usually cervical carcinoma will metastasis to the hematogenous spread will be more common or local spread will be more common. Then to the regional lymph nodes, lung, liver, and bone marrow and kidneys will be usually infiltrate, will show some metastasis in the late stages. So the growth again it's similar to your penile carcinoma. Either it can be an endophytic or exophytic or an infiltrative, also infiltrative growth. Here you can see actually a cauliflower-like tumor mass. Squamous cell carcinoma, depending upon the keratin first and epidemization, it is again classified into graded into well, moderate, and fully differentiated squamous cell carcinoma. Next comes to the adenocarcinoma, or it can be actually adenosquamous carcinoma. Then you should know about the phygoclinical staging of carcinoma of the cervix. Main thing, stage 1 is nothing but the lesions will be usually less than the 4 centimeter in the size, and it should not cross more than the 7 millimeter across the basal epithelium. Stage 2, stage 3 will be stage 2 extends beyond the cervix. Stage 3 will be to the pelvic wall, the lower third of the vagina, or to the kidney and the other places. Stage 4 will have a bladder and the rectal involvement. At least you remember this thing before you finish your figure staging. Then comes to the endometrium. Endometrium, first you have to know about the normal phases of the endometrium. That is your proliferative secretory, late secretory, the shedding endometrium. Then endometrial hyperplasia. Endometrial hyperplasia has been classified into, previously it was classified into simple hyperplasia with atypia, without atypia, and complex hyperplasia. Now it has been replaced as hyperplasia with atypia and without atypia. When you have endometrial intraepithelial neoplasia, then you have an endometrial carcinoma. But among them, at least you should know the normal endometrium. Proliferative endometrium will be tubular glands. Glands and stroma will have the equal ratio. Tubular glands will be there, lined by columnar epithelium. Whereas secretory will be corkscrew shape or dilated glands will be there, which will have an either a intra subnuclear bacillation or the supranuclear bacillation, depending upon the stages of the secretory phase. And stroma will be more edematous with a lot of spiral arterioles will be present in case of secretory endometrium. And most important will be our shedding endometrium. At least you remember proliferative and then secretory phase. Then comes to the hyperplasia. Hyperplasia, it has to correlate with your radiological finding. Thickness of the endometrium should be more than actually 3 centimeter. And when you do an microscopic examination, the stromal as well as glandular proportion will be usually reversed. It will not be in 1:1. Glands will be more rather than the stroma with back-to-back arrangement. Multiple pseudo stratification of lining epithelium will be seen in the lining glands with the minimal intervening stroma. Okay. So this glandular lining epithelium, if it shows atypia, we call them as hyperplasia with atypia. If it doesn't show atypia, we call them as simple hyperplasia. And then sometimes The same thing, this atypia can be a more pronounced, highly pleomorphic cells with high degree of atypia and necrosis, and the mitosis figures are more common. But everything is only in the focal area. We call them as endometrial intraepithelial neoplasia, similar to your carcinoma in situ in case of cervix. The most common infections which are identified in endometrium will be your like here in tuberculous architis. Here also tuberculous endometritis will be more common. In Indian population, this is the most common feature for the infertility. And comes to the endometrial carcinoma, as you all know, diabetes and obesity is one of the cause for the development of this endometrial carcinoma. It is more common in the perimenopausal or in the postmenopausal age group, or most commonly it may present as a postmenopausal bleeding, usually due to chronic unopposed action of the estrogen and hypertension and the nulliparous status. So it is often associated with genetic mutation of P10, KRAS, and beta-catenin. Remember this 4 gene, very, very important. And grossly, it has two pattern of tumor. Either it can be a polypoidal tumor or it can be a diffuse infiltrating tumor, irregular friable masses. It is nothing but endometrial adenocarcinomas. So it's a friable growth arising from the endometrial mucosa invading the underlying myometrium. Depending upon the myometrial invasion, less than 50% or more than 50%, it has been graded into higher grades of tumor. And then adenocarcinoma also, you know, depending upon the differentiation of the glands, it has been graded into well differentiated, monodifferentiated, and polydifferentiated. And this is the figure staging for the endometrial carcinoma. Next comes to the leiomyoma. Leiomyoma I have completed, so I have skipped it. So this is about your FTT. Then comes to the breast. So breast, you should know about the classification of breast tumors. Classification of breast tumors includes benign and the malignant. Benign, you have a whole list. The most common will be fibroadenoma and phyllodes. Then comes to your tubular adenoma and then lactating adenoma and other things. Then malignant tumors are classified into either a carcinoma in situ or an invasive carcinoma. Carcinoma in situ, again, it is classified into ductal or the lobular. Invasive can be classified into invasive ductal, lobular, and then inflammatory carcinoma. Or sometimes other things will be metaplastic carcinoma, or it can be lymphomas or metastasis to the breast. Stromal tumors, the benign stromal tumors are called as in phyllodes. Malignant stromal tumors, it can be malignant phyllodes or it can be a other malignant sarcomas that is also common in the breast. Then other variants other than the IDC will be your tubular, medullary, mucinous, and then papillary. So just at least know the whole classification of breast tumors. But among them, we are going to see about fibroadenoma, phyllodes, and then invasive ductal carcinoma. Fibroadenoma, the most important microscopy only. It's actually a well-defined, well-encapsulated, well-circumscribed gray white tumor. Okay, and it will show in slit-like spaces. You can able to see the slit-like spaces. Nothing but compressed ducts. It appears as slit-like spaces, and myxoid background will be more common. But microscopically, two patterns will be identified. One is intracanalicular or the pericanalicular. That is very important. Depending upon the pattern, I mean amount of the pattern, it has been classified intracanalicular and pericanalicular. Myxoid degeneration will be more common. This is an intrarectal papilloma, where you can see papillary fronds, which will be lined by the double layer epithelium. All the glands will have double layer epithelium, interductal layer lining epithelium, that will be columnar or cuboidal lining epithelium, and then outer myoepithelial layer. Okay, this is the phyllodes tumor, usually large tumor, more than 10 centimeter in the size, leaf-like compression of the ducts will be usually seen, and you have multiple cystic spaces. So that will be the classical picture of Phyllodes tumor. Depending upon the nuclear atypia, mitosis, necrosis, and other degenerative changes, and the size of the tumor and the underlying invasion, it has been classified into benign phyllodes, intermediate phyllodes or borderline phyllodes, and then malignant phyllodes. Actually, stromal overgrowth, nuclear atypia, mitosis, and necrosis. This only will be considered to classify them as benign, borderline, and the malignant. So here you can see the leaf-like pattern, compressed ducts. This is a benign phyllodes, and the mitosis will be usually less than 4 in case of benign phyllodes. So next comes to the stromal tumor. Remember the phyllodes growth, gross picture, microscopy, compressed ducts. Only the stromal proliferation will be seen in case of stromal overgrowth, which is nothing but your spindle shaped fibroblast. That's all. Next comes to your infiltrate carcinoma, IDC. So IDC, you all know, usually we'll receive radical mastectomy for an IDC. Here the tumor cells will be arranged in the nest, pods, of the glands, which will be separated by the stroma. The lining epithelium will show an abnormal nucleus feature with atypical nuclear features. And one more thing, absence of myoepithelial layer. And they will be surrounded by lot of desmoplastic stroma, and calcification will be more common. Usually within the tumor, it will show lymphovascular invasion, perineural invasion. This is a infiltrating lobular carcinoma. It is a specific pattern of tumor cells. Uniform tumor cells will be called as an Indian file pattern. As like Indian soldier, how they are walking, it will be regular in shape in the single linear fragment. So they are called as an Indian file pattern, which is classical about invasive lobular carcinoma. The difference between IDC and invasive lobular carcinoma is invasive lobular carcinoma, the size of the lump will be usually smaller, whereas IDC can go in the higher size of the tumor with a lot of degenerations will be there. Whereas lobular carcinoma will show some minimal degeneration. Another important thing is invasive lobular carcinoma will have hematogenous spread, whereas ductal carcinoma will have a lymphatic spread. Through the axillary lymph node, it will go to the other lymph nodes. And bizarre appearing nucleus will be more common in case of IDC, whereas it will be a monomorphic nucleus will be in case of invasive lobular carcinoma. Bilateral tumors will be most commonly invasive lobular carcinoma, whereas single breast tumor, which is an IDC. So next comes to the pages. This is nothing but involvement of, you can see here, skin of the nipple with lot of fissuring and clustering and ulceration, and oozing will be there. So pages is nothing but individual. These are the tumor cells which are infiltrating the nipple and areola. It can be in single or small clusters within the epidermis of the tumor, epidermis of the breast. That is called as pages disease of the breast. So with this, we have finished the breast. Then very quickly, another 10 minutes, I'll finish off all other things which has to be considered in the exam. In bone and soft tissue, as you all know, the common bone tumors, first more important thing will be a fracture healing. That is very important. These are the questions which have been asked to be concentrated. Okay. I'll give you this PPT in your WhatsApp group. You can go through it, so that it will be helpful in preparing your last minute revision also. It will be very helpful. Fracture healing, you have to must know stages of fracture healing, from the hematoma till the remodeling, and microscopically callus formation you have to know in the fracture healing. Another important in bone pathology which you have to read will be revise avascular bone necrosis, osteonecrosis, causes of avascular bone necrosis. That's a very important short notes. And then uh, osteomyelitis, very important, including tuberculous osteomyelitis has to be read. Spread, pathogenesis, common organism, common risk factor, then complications of osteomyelitis, very important. Potts disease, as you all know, it's a tuberculous osteomyelitis, otherwise called as in Potts disease. So read about them. So you have to know spread everything. Then in the osteomyelitis, the dead bony trabeculae are usually called as sequestrum, which will have an empty lacuna. I'm sorry. Then comes to your newborn formation, which is called as an involucrum. And within that, you have stromal spaces will show a lot of inflammatory infiltrate. That will be the classical features in case of osteomyelitis. Read about the causes of pathological fracture. That is another important thing. Extrapulmonary tuberculosis presentation, where the vertebrae are involved. Most common lumbar vertebrae are involved, or lower thoracic vertebrae are involved with the tuberculosis infection. Is called as a pox spec. Okay. Again, what you are going to see only the granulomas. Caseating granulomas will be seen on microscopically. Clinical presentation, they can have deformities. Spinal deformities will be more common with paresthesia and muscle weakness. And is avascular necrosis, at least you know it is an ischemic necrosis where vascular interruption occur due to fracture or sometimes on long-term on corticosteroid therapies, or pathologically it can be associated with hemolytic anemia, especially with the sickle cell disease. Common site will be your fracture, femoral head will be usually involved. I'm not going into pages. This is bone tumors. Read about the classification of bone tumors. Benign tumors will be osteoma, osteoblastoma, osteoblastomas, and osteochondromas. And then malignant, most common will be your osteosarcomas, saline sarcomas. Osteochondromas will be usually a bony capped cartilage overgrowth. Remember, it can be single or it can be multiple. If it is multiple, usually associated with hereditary disorder called as a multiple hereditary exostosis. Here you can see it is a mushroom-like growth, which is then outcapped by the cartilage overgrowth. So this is a specific gross picture of osteochondroma. Then osteoclastoma, again very important, which is called as a giant cell tumor. I'm not going into details. Kindly revise them. Here the giant cells are actually tumor cells. Then comes to your osteoid sarcoma, which is usually involved, it's a malignant tumor, involve the metaphysis of the long bone. This is a fish flesh-like appearance will be there. Radiological picture is very important case of osteogenic sarcoma. Sunburst-like appearance. Okay, classically they'll give 20 years, 25 years of old young male presenting with bony outgrowth near the humerus with sunburst appearance. Okay, or triangular space elevation within the tumor and the outer link cortex. Anything can be possible. So with this radiological picture, usually we'll come to a diagnosis of osteosarcoma. Osteosarcoma is a classical variant of osteosarcoma, but here we have so many variants like telangiectatic osteosarcoma, giant cell osteosarcoma, condyte producing osteosarcoma. So many osteosarcomas are there. Okay. Then this is very rare to get chondrosarcomas, but chondrosarcomas, just you know, it is a malignant tumor which arises from the chondroblast. And we have other variants like conventional chondrosarcoma, clear cell, dedifferentiated, and mesenchymal chondrosarcomas. Then this is about the bone tumor. Before going to the joint spaces, rheumatoid, gouty arthritis, and then osteoarthritis, I'll finish soft tissue tumors. Most commonly, lipoma will be the common soft tissue tumors. You all know. And its malignant counterpart will be liposarcoma. And then muscle tumor will be rhabdomyoma and rhabdomyosarcoma. Nerve tumors, you have to know about neurofibromas and the schwannomas. Okay. And then vascular tumor, we all know about cavernous hemangioma, capillary hemangioma, and that's all. So lipoma, leiomyoma, hemangiomas you will know capillary, and then cavernous hemangiomas, and then the malignant counterpart will be your liposarcomas and the rhabdomyosarcomas. In this rhabdomyosarcomas, embryonal rhabdomyosarcomas are more commonly occurs in the nasal cavity or in the vulval regions. Then schwannoma. You all know schwannoma will show hypocellular Microscopically, it is otherwise called as neurolemoma. And grossly, it is a well circumscribed encapsulated tumor that are attached to the nerve. And remember, it is a well circumscribed encapsulated tumor. That is the basic difference between your schwannomas and the neurofibromas. And schwannomas, if it occurs at the cerebellopontine angle involving the eighth nerve, it is called as acoustic neuroma. And microscopically, we have two patterns, Antony A, Antony B pattern with the presence of Verrucay bodies. So Antony A will be dense cellular elongated cells with the arrangement of fascicles will be there, and nuclear palisading is usually called as in Verrucay bodies. Then Antony B will be the hypocellular layers. Then comes to the neurofibroma. Cutaneous neurofibroma, we all know, most commonly associated with neurofibroma type 1, fibromatosis type 1, and plexiform neurofibromas. These are the multiple neurofibromas associated with neurofibromatosis type 1 and type 2. You will have a delicate collagen, mast cell press, and the dermal proliferation of cells with a wavy nucleus, nerve nucleus will be elongated. Then comes to the disease of joints, osteoarthritis, slow progressive disease, usually occurs above 50 years of age, and then inflammatory mediators are the most common cause of cartilage matrix degradation, commonly involve the larger joints, and then morphologically they present with articular loose bodies, then bony abomination, then lot of inflammation and osteophyte formation. Okay, so this is about osteoarthritis. It can have secondary infections. Then osteoarthritis can be primary or the secondary. Primary is idiopathic. Secondary will be associated with your hormonal replacement, type of work, second to the trauma, crystal deposition defects, or metabolic diseases like diabetes. Okay, then comes to rheumatoid arthritis, which is an autoimmune disorder, chronic inflammatory disease, where antigen antibody complex will be there, which will get deposited under the vascular spaces where there is going to be fibrinoid necrosis. Most commonly involve the small joints such as interphalangeal joints and metacarpal joints. Elbow, knee, and ankle will be the next common. Other organs involved will be skin, blood vessel, heart, lung, and the muscle. Most commonly, they say it is due to post-viral infection, pannus formation, synovial hyperplasia, the intense inflammatory infiltrate. Remember these four important things. Here, this is a rheumatoid joint. The rheumatoid joint is being infiltrated by the macrophages and the plasma cells. So, immune complex mediator will be deposited over the blood vessel, and there is going to be a giant cell reaction because of this macrophage. So, there is stellate kind of necrosis which is surrounded by giant cells which are giant cell formations which will be usually identified microscopically with synovial hyperplasia. Okay, I've given you some pathogenesis which I'm not going into that. At least remember this morphology: synovial hyperplasia, villus formation, pannus formation, dense inflammation and lymphoid follicle formation, and rice bodies. So these are the synovium is replaced into finger-like projections. Hyperplastic synovium, skin, you can see the typical nodule with the pannus formation, central necrosis. This is called a geographical necrosis, surrounded by granulomatous reaction. Okay. Then comes to the gouty arthritis. This is heterogeneous group where there is a hyperuricemia, deposition of urine crystals. So mainly defect in the enzyme of hypoxanthine guanine phospholipid transferase. Or it can be impaired uric acid excretion due to the drugs like thiazide diuretics. Chronic renal failure is the most common cause. Either an increased urine acid production or decreased urinary metabolism. That is the main cause. High alcohol, obesity, drugs. These are the most common cause. Or intake of purine, increased purine. That is also one of the important cause. So it can present as acute arthritis, chronic tophaceous arthritis, or it can be a tophi in the soft tissue. So most commonly grade 2 will be involved. Articular cartilage will be involved. You have articular cartilage degeneration. This is a tophi nodule in the finger. So you can see this urate crystal deposition. It will be identified on the cut section. And by Negative birefringent fluorescence will be more common. So in the brownish monosodium crystals it will be identified. So this is the tophus, which shows the uric acid crystal for deposition, which will appear as a brownish discoloration. So these are the sites of deposition. So this is about the bone. So in the bone, you have to know about classification of bone tumors. Giant cell tumor is very, very important. Avascular necrosis. Then comes to your malignant tumors, osteosarcoma, ewing sarcomas, and something about the chondrosarcomas. Then osteomyelitis, avascular necrosis of the bone. In joint, you have to revise about osteoarthritis and then rheumatoid arthritis and gouty arthritis. Then comes to the skin. Skin precancerous lesion, similar to a precancerous to the penis, acne keratosis, Bowen's disease, and leukoplakia, oral cavity, which will present as a whitish patch. Again, associated with an human papillomavirus and other thing. I'm not going into detail. Again, malignancies, common cell carcinoma will be most common, as you all know. And differentiation also. I have told you everywhere what are the this thing. Other important premalignant lesions will be a keratoacanthoma, marjolin ulcer. Marjolin ulcer will be usually post burns and then serial keratosis. Then other than that, you should know about the basal cell carcinoma, specific microscopy about the basal cell carcinoma, and then melanomas. Okay. So we'll go ahead with your basal cell carcinoma and melanomas. So basal cell carcinoma is otherwise called as a rodent ulcer. It's a tumor derived from the basal cell layer of the epidermis, and it does not metastasis. It crave by itself at the place, so locally it is invasive, and recurrence will be more common, and sun-exposed areas will be more common. Especially it is seen at the angle between your eyes and the mouth, and then the usual pathogenesis is there's a dysregulation in the hedgehog pathway and PTCH gene, which is a tumor suppressor gene, which will usually rectify the hedgehog pathways in the cellular proliferation, and then P53 mutation will be the most common in the basal cell carcinoma. It can be a papule, it can be a nodule, or it can be an ulcer. So it is otherwise called as a rodent ulcer. Now, tumor cells will resemble to the normal epidermal basal cell layer with less pleomorphism, hyperchromatic nucleus, and here the tumor again it will be invades from your epidermis into the dermis. Multiple lobules of tumor cells will be there, which will have a peripheral palisading. An important thing will be there will be a cutting artifact will be seen between, which will be separating your epidermodermal junction from the tumor nodule with the peripheral palisading. See here, you can able to see this cell. This is the artifact space which has been created between the underlying stroma and the tumor cells with the peripheral palisading of the nucleus. Then comes to a malignant melanoma. So it is usually arises from the melanocytes from the base layer of the epidermis. And the premalignant lesion for the malignant melanoma will be usually nevus, especially the dysplastic nevus. So read the difference between the dysplastic nevus and the melanoma. That is also very important. And usually melanomas will have a worse prognosis. And one of the counterpart of the melanoma will be amelanotic melanoma. Just to know the name, there is another counterpart which is called as an amelanotic melanoma. And a hereditary predisposition, multi-step mutation in precursor lesion. They are the most common pathogenesis. Sunlight exposure, UV radiation, and DNA damage. Then there are two types of growth of pattern will be there. One is radical growth pattern and then vertical growth pattern. BRAF mutation, KRAS mutation, remember, read about them, how does it involves in the germline mutation and make the patient genetically predisposed for the UV-induced DNA damage. Then clinical warnings will be nevus, sudden increase in the size of the nevus, it become painful, and new lesions can be erased with irregular borders, increase in the size. All this will be the usual clinical symptoms. Metastasis to the regional nodes, liver, lung, and brain. Okay, just know the ABCD of the melanoma. Okay, so here you can see these are the tumor cells. The most important thing about the melanoma will be prominent eosinophilic nucleoli. Okay, Can you able to see here? Each individual cells are showing prominent eosinophilic nucleoli with a lot of atypical mitosis will be seen on their background. Okay, but there won't be any necrosis. Again, it is a glandular nodular growth pattern will be there. So this is about your skin. So skin, again, I have revised what are the pre-malignant lesion, acne keratosis, then Bhavani papulosis and leukoplakia, then squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. Then comes to the endocrine. I'm not going into details because it's going to be already very late. Remember, read about your Hashimoto thyroiditis. Then in malignancy, at least you have to know what are the classification of thyroid tumors. Then papillary carcinoma. At least you should know something about your follicular carcinoma, medullary carcinoma. Then comes to your pheochromocytoma from the adrenal. Okay. Then multiple endocrine neoplasia. Just I think I can go through it. So thyroiditis, you all know Hashimoto's will be most common. Autoimmune thyroiditis. Hashimoto thyroiditis, you have an arthritic follicles within the dense lymphoplasmacytic infiltration and lymphoid follicle formation. And the background of Hashimoto thyroiditis, most common carcinoma, which usually arises, will be a papillary carcinoma. Remember, 90% of your Hashimoto thyroiditis will lead to a papillary carcinoma. It is usually a nodular Hashi that will lead to nodular papillary CA. And most important thing will be a Ashkenazi changes. This is actually a lymph node lymphoid follicle within the Hashimoto's with active cetrocytes and cetroblasts. These are arthritic thyroid follicles. Remember, you have to read about your pathogenesis of Hashimoto's antigens, how they are directed against your TSH and T3 and T4.
Hello, ma'am. Hello.
I'm sorry,
Hello,
ma'am.
ma'am.
Can I able to hear, ma'am? Am I audible, ma'am? My
Yes,
Wi-Fi
ma'am.
has been
Now you are clear, ma'am. In between, like you are not heard.
sorry, ma'am. Sorry, ma'am. The
Yes,
last thing, last part which is left over will be thyroid, and then CNS is there. Just or 10 minutes, ma'am. I'll tell them what are the important questions, and then I'll leave them.
yes, ma'am. Yes, ma'am.
Can you able to see thyroid neoplasm? Just these are the malignancies. Important thing about this thyroid, you should know about the FNACs. What do you mean by final aspiration cytology? And we have a specific reporting system in the FNAC, which is called Bethesda categorization for the thyroid. There is actually 5 categories are there. Category 1 and 2 will be, 1 will be usually inadequate material, 2 will be usually benign, and 3 will be ATP of undetermined significance, 4 will be the suspicious of malignancy, and 5 will be the malignancy. At least you remember this category is used for categorizing the thyroid nodule in FNAC. FNAC can be asked as separate question. Please go through it, and you have to prepare a specific notes under the FNAC. Final aspiration cytology. And these are the thyroid neoplasm. So benign will be usually adenomas. Malignancies will be carcinomas. Most common will be papillary carcinoma. Then comes the follicular carcinoma. And one of the drawback by the FNAC will be papillary carcinoma, conventional papillary carcinoma, other variants can be diagnosed with the nuclear features. Whereas follicular carcinoma, you have to look for the capsular invasion and then lymphovascular invasion, which cannot be identified by the FNAC. So only by the biopsy, we can be able to differentiate the follicular carcinoma. Okay. Uh, so follicular adenoma will be well differentiated tumor. We have a microfollicular adenoma, microfollicles back-to-back arrangement with a lot of thyroid within them. with a lot of secondary degenerations will be more common with the follicular adenomas. At least you remember this thing. There is no ATP or no this thing. One more thing, follicular adenoma can shows Hurdle cell change. If it shows Hurdle cell change in more than 70% of the tumor, it is called as Hurdle cell adenoma. Okay. So this is an example of Hurdle cell adenoma. This is in follicular adenoma. You can see multiple follicles. These are the multiple follicles filled with the colloid, which are lined with the cuboidal lining epithelium. Whereas this is the Hurdle cells, which will show eosinophilic cytoplasm, which will be an oncocytic-like type of cells will be there, which usually seen in the Hashimoto's. Then follicular carcinoma. So it contains a lot of follicles with a capsular. You can see here there is a capsular invasion. Okay. So without capsular invasion, without follicular invasion, you cannot call them as a follicular carcinoma. So this is a papillary carcinoma, most important papillary carcinoma. In conventional, you are going to say it is a true papilla. Central fibrovascular core will be present, which will be lined by your pleomorphic papillary columnar cells. Okay. And one more thing, I've told you previously also, any papillary tumor can show dystrophic calcification. Again, here you can able to see some more bodies. Okay. Next thing will be the nuclear features. Nuclear features will be either optically clear nucleus or you can have a orphan Annie nucleus. I'll show you a picture. So this is an orphan Annie nucleus. Okay. Or there can be intranuclear inclusions or intranuclear separations. So that are called as little orphan Annie nucleus. Okay. So these are the specific nuclear features which will see. This is a ground glass appearance. Ground glass appearance, we can see there will be a constriction will be there in the both the sides of the ground glass. Similarly, the nucleus will appear. That is called as ground glass appearance. This is the some more bodies. Okay. Other variants, at least you should remember the names of the other variants of papillary CA, encapsulated variant, follicular variant, tall cell variant, diffuse sclerosing, and then hyalinizing trabecular variant. Just you know the names, that is enough. Sometimes in MCQs, they may ask you whether it's a variant of papillary CA. Okay. Most common will be lymph node metastasis. Axillary node metastasis will be more common. Very rare to have a distant metastasis, but it is possible with papillary CA. It may go to lung, liver, as well as to the brain. Okay. And medullary thyroid carcinoma. More important thing in medullary carcinoma thyroid will be germline mutation and red proto-oncogen. So it comes under MEN2A. Along with your pheochromocytoma, parathyroid adenoma, or an adenoma or parathyroid hyperplasia. That is the most important thing which I want to this thing. Or it can be associated with your MEN2C, which is associated with pheochromocytoma of adrenal gland or mucosal ganglioneuroma, and then other skeletal abnormalities and morphinoid features. Other than that, histologically and all, main thing you have to know, the tumor in between the tumor stroma, there can be deposition of amyloid, which will be stained only by the Congo red. So, which is a classical about the medullary thyroid carcinoma. I'm not going into anaplastic. Okay. So, prognosis, papillary will have usually better prognosis rather than worse prognosis in the anaplastic. Secondary tumors to thyroid is very, very common. Most commonly, it will goes from renal. So, clear renal cell carcinoma can, clear cell renal carcinoma usually metastasis to the thyroid. Okay. Then comes to your diabetes. That is pathogenesis. You have to know what are the category. Then HbA1c is very, very important. MODY, pathogenesis of MODY is important. Classification of MODY into 1, 2, 3, 4, 5, 6. Depending upon the mitochondrial DNA mutation, you have to know. Then gestational diabetes mellitus. What are the criteria for gestational diabetes mellitus? And then before reading your diabetes, please read about your insulin action and then insulin metabolism. That is very, very important. Until you understand your insulin metabolism, you cannot able to say about your active glycosylated end products, which are the major pathogenic in producing all the complication of the diabetes. Then read about the complication of diabetes, especially diabetic ketoacidosis. Then the macrovascular complication, diabetic retinopathy, nephropathy, and neuropathy. At least diabetic nephropathy. Nephropathy, remember the 5 lesion in diabetic glomerular sclerosis, papillary necrosis, pyonephrosis, or a diabetic pyonephritis. Anything can present with the diabetes. Nephrotic syndrome will be the common thing, or sometimes it will present as only an end-stage kidney disease with chronic pyelonephritis features. So I have given here all this glucose homeostasis, insulin metabolism. Please remember, unless until you are clear with your insulin metabolism, you will not remember any kind of your pathogenesis with your glycosylated end products. Okay. So it's going to affect your liver metabolism, thyroid metabolism, everything. And it is an autoimmune disorder with beta cell destruction. Genetic insusceptibility is more common. And other important factors which are in current research will be your inflammatory mediators and then tissue necrotic factors. Okay. So remember these environmental factors, viral infections also sometimes will cause this diabetes. And I have put in, but since read about all these things at least, you should know these pathways and complications. Okay. And any other thing? Ketoacidosis, treatment of ketoacidosis. Remember what are the ketone bodies? How they are you have to going to diagnose them? Acetoacetic acid and nucleic acid. Remember the investigations. Remember the ketogenic pathway before you read about diabetic ketoacidosis. Then hyperosmolar non-ketotic coma. Then lab diagnosis of diabetes is also very important. In that HbA1c, what is the specific about the HbA1c? Kindly read. I have not given here due to lack of time. Then comes to the pheochromocytoma. Rule of 10. 10% will be usually extra-adrenal, 10% will be bilateral, 10% will be malignant, and it may not be associated with the early hypertension, and most of them it can be familial. Gene mutation, HIF1 alpha is the most common mutation, then red oncogen mutation, then comes to your NF1 and the von Hippel-Lindau syndrome. Okay, and it's a well circumscribed tumor, yellow and tan in color usually, with hemorrhage and necrosis and cystic lesion. So here the cell balloon appearance. This is called a cell balloon appearance. Cell balloon appearance. Okay, which is specific about the pheochromocytoma. So it consists of polygonal to spindle shaped cells supporting the cystanuclear cells within the small nest or the alveoli of the tumor cells. And cytoplasm usually be granular, which contains a lot of catecholamines, salt pepper-like appearance. Specific thing for the pheochromocytoma. And most of them will present as a hypertension, blood pressure in the younger adults will be the most common clinical symptoms and clinical picture, which will be precipitated by your excessive stress, emotions, and then they can present with excessive palpitation, which usually be treated by the beta blockers. Lab diagnosis, you all know, vinyl manelic acid, free catecholamines, and metabolites will be increased. Then remember about Men's syndrome. Kindly read about the Men's syndrome. Men's syndrome is a typical 5-mark question. Okay. Multiple endocrine neoplasia. So most commonly it involves parathyroid, pancreas, and pituitary. So men 1 is Werner syndrome. Men 2A will be Sippel syndrome. Men 2B, there is no specific syndrome, but it's usually associated with medullary thyroid, pheochromocytoma, mucocutaneous neuromas, and Marfanoid diabetes. So I have given here the picture. Pathogenesis, at least you remember red oncogen mutation. That is important. Then comes to CNS, your last chapter. So meningitis, you have to read about meningitis, very, very important. CSF, lumbar puncture, septic collection of your CSF. And then indication of the CSF can be asked in your Viva question. Whether what are the therapeutic indication, what are the diagnostic indication for the CSF. Then site where you collect your CSF. Then collection of draw of CSF is also very important. Then tabulate the differences of CSF features between your pyogenic, viral, bacterial, and tuberculous meningitis. That is very important. Then the last will be your fungal meningitis. That is cryptococcal fungus will be most common. I'm not this thing. Please, I'll give you the for a revision. I'll give you the PPT. Kindly go through them. I'm sorry, I'm not able to follow it up. So, see here, I've given you the differences in the normal, acute pyogenic, and then acute viral meningitis and the chronic tuberculous meningitis. Most commonly, the 6 should be there to get your whole mark. This can be asked in a 10 mark also. Naked eye appearance, CSF pressure, and then cells, glucose protein, and the bacteriology. Okay. Then tumors. Among all the tumors, meningioma will be the most common to ask for the UG. This thing, most frequent question. So meningiomas, usually it is a well circumscribed solid tumor. We have a spinal meningiomas also. So these tumors will be generally firm, which will be attached to the underlying dura matter. Cut surface will be usually fibrous in nature. So it's a well circumscribed mass. Okay. So here, microscopic appearance, you can see the syncytial cells. The cells will resemble like your arachnoid cap cells, which are polygonal in shapes with a defined membrane arranged in the syncytial appearance with central somo bodies. Whorled appearance with central somo bodies can be identified. Many of the whorls can be seen. Sometimes this may show xanthomas or myxomatous degeneration within the tumor. Another important CNS tumor will be intracranial schwannoma. I have already explained you in a soft tissue how the schwannoma will appear. Similarly, it has both the pattern, Antony and Antony B pattern with the vericay bodies. And multiple schwannomas are also more common if it is associated with the CNS schwannoma, especially in von Recklingh's disease. The other name for the schwannoma will be neurilemoma. Okay. It is as I told you, it is a well encapsulated, well circumscribed tumor. Fish flesh-like appearance, soft with hemorrhagic and calcification. I've given you again the picture of Antony, Antony B, and this parasitic nucleus is called as a vericay bodies. That's all I think so. I have actually done a very fast revision. If any one of you have any kind of difficulties in any of the topic, you can specifically call me and then you can message me in the group. I can able to reply you, or I can send you some material which will be useful for your revision. Thank you. Thank you, ma'am. Vani, ma'am.
Thank you so much,
Sorry,
ma'am.
ma'am, I've
I'm
taken
really
half an
sorry.
hour
My
extra.
apologies, ma'am.
Sorry, ma'am. I've
I
taken
submit my
half an hour.
apologies, ma'am. Like suddenly I had to go to a temple, so I directly from college I went there. So
Okay, ma'am.
our
Okay.
mobile was silent. I'm sorry.
No
So
issue, ma'am. No
students,
problem.
wait for 1 minute. We'll do the Shanti mantra and then finish the thing. You have waited for this long. We'll do the NMO mantra and the Shanti mantra together. न त्वहं कामये राज्यं न स्वर्गं न पुनर्भवम् कामये दुःखतप्तानां प्राणिनाम् आर्तिनाशनम् सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः. Our sincere thanks to Bhavani ma'am from Mahatma Gandhi Medical College, Professor of Pathology,
Thank you,
for
ma'am. But I don't know
consenting to
whether
take
I've
the
done all,
session.
everything perfectly. If anybody has any difficulties, they can ask me at any time. They can message me, ma'am.
Sure, ma'am. Sure, ma'am. So with this, we come to the end of the rapid erosion program of 12 sessions. So I thank every faculty who took and also all the students who enthusiastically joined and clarify your doubts. Hope the sessions were useful for you. Can I get a word or two from the last 2 or 3 students who have joined the session? Or messages in the chat box, please. Hope you joined the other sessions too.
Yes, ma'am.
Yes, Akash, introduce yourself and just a word or two.
My name is Akash, ma'am. I'm from Stanley Medical College.
Yes.
The classes is conducted was very useful for rapid revision. So thank you very much.
Thank you, Akash. Shyam Ganesh.
Yes, ma'am.
Thank you. You are from
So,
which college, pa?
I'm PSG. I am, sir.
Oh, good. Thanks for joining and waiting till the end. Good. All the best to
Thank
all of
you.
you. Thank you so much, ma'am. Well, I'll upload all the videos now, one by one. Thank you, ma'am.
Thank you, ma'am.
Thank you.